Okay, thank you, Andrea, for your talk, and I present the next speaker. Gavin Doherty from Trinity College. The name of his talk is
different to that. So
yeah.
Bring it up in a second. Well, just like.
Okay. His technology to support mental health, engaging teenagers with psychotherapy using mobile phones. Thank you, Gavin.
Okay, so I think that's going to be a hard one to follow. It's a very interesting talk there. I'm mostly today going to talk about work that was done together with Mark Matthews, who was a PhD student of mine, now postdoc, split between Cornell University and Trinity College. So we've been working to develop technologies to be used to support mental health treatment for a number of years. So why are we trying to do this, first of all? I mean, if there's no major problem, then maybe we don't need to interfere using technology. So first of all, as we're all aware, ADHD being part of the overall problem of mental illness, but many countries and services, health services, are struggling to meet the demands placed on them in terms of mental illness. So this is a problem of access. A lot of people just can't get access to treatment. Secondly, then, partly due to the stigma surrounding mental illness, is even where appropriate treatment options are available, a lot of people are unwilling to engage with services. So they really, until they get into a very bad state, they really don't want to go to a service. And finally, even where people have decided to seek treatment, they might find it difficult to actually engage with the treatment or to maintain adherence to certain things that they're supposed to do. So this is the issue then of engagement. So we've got access and engagement as being big problems. And of course, when we talk about children and adolescents, both of these actually can be worse. Certainly the child and adolescent services that we've had contact with seem to be very overburdened in terms of their workload, and they've got a lot of difficulties engaging young people with treatment. So the challenge then is a quote here from Kasdan saying it's to involve the child in treatment and to work toward a change that the child may not view as necessary or even potentially useful. So this is a tricky problem and something maybe that we can help to address using technology. So children, first of all, are not really used to talking about their kind of innermost thoughts and feelings, and particularly doing this with a stranger is a very difficult thing to ask them to do. As I've mentioned, therapists can often be overburdened, and so having a child sit there with their arms crossed, not saying much for several sessions is not really a great use of resources. And also there's the perception on the part of the children and adolescents that these paper-based materials are kind of outdated and not very engaging to them. So we've looked at a couple of different ways of engaging young people with psychotherapy. So we did a series of projects around the area of therapeutic games, so taking psychoeducational material and strategies and embedding them into a computer game where the child goes around, meets various different characters, has conversations with them. The characters introduce videos, they fill in questionnaires, they answer questions and so on. So the initial game we did was called Personal Investigator. It supported brief solution-focused therapy. After that, we built a tool to allow therapists to author games, and so we had cognitive behavioural therapy games that try to communicate the essential concepts of CBT to children, which are not necessarily easy for them to grasp. And really, we were trying, firstly, just to act as an icebreaker. So if you get the child talking, maybe you don't need the game after the first session. That's fine. But as we got into it, we found that actually the game could help to open up the therapeutic space a bit, help to build a therapeutic relationship and to provide a context and in some cases a language for conversations then with the therapist. So that's within the sessions where the child sits down next to the therapist and plays the game. We've also looked at a slightly older cohort in terms of young adults and so on, at engaging people in online treatments. So these can work if people actually do them, but if you just point at somebody at a computer system and say, off you go, they're likely not to do it. So we've looked at computer-supported treatments where there's feedback from a real person, so a psychotherapist, a psychologist, or a trained support worker. What I'm going to talk about today, however, is engagement in activities then between sessions. So this is a kind of simpler example to talk about. So the idea here is that if we engage young people more in their own treatment between the sessions, get greater adherence to therapeutic activities, well, that in itself could be a nice outcome, but this could also lead to a greater sense of self-efficacy. They're successfully carrying out these things. They've some element of control over the therapy, and this in turn can lead to positive outcomes because self-efficacy is associated with better outcomes. So the example I'm going to talk about is mood charting. So this is something that's used by several therapeutic approaches, so it's a flexible tool. We don't need therapists who are committed to some specific approach to therapy. It's used for a range of different disorders, including, in some variants, ADHD. With mood monitoring or mood charting, the child is self-recording their own emotions and maybe things like sleep, energy levels, and so on. They record these feelings, and in the past this has been done with paper diaries. So if this is done, then this provides information to the therapist or psychologist, maybe making decisions on medication, for example. For the person themselves, they might be able to identify changes or patterns kind of in their own behaviour, so develop greater self-awareness. Having this material before the child goes into the session can help to save session time because they're not trying to reconstruct the previous period, or can provide cues as to interesting things maybe that should be asked. And it gives access to this sort of invisible time between sessions. So again, if paper charts were working fine, there would be no point in looking at technology. But it turns out there are a lot of problems with paper. So the major problem is low adherence. So they really tend not to be filled in very, very often. In the case of children, they tend to be lost, or they're terrified somebody's going to find it. So they don't typically get carried out very reliably. So Stone did a study with instrumented diaries which found an adherence rate of 11%. Okay, this was quite different to the reported rate where people said they were doing it, but in reality they weren't actually doing it very often. If you want to gather some corpus of data, let's say for decision making, then somebody's got to type in all of this information, so that's pretty time consuming, and the therapists we work with typically don't have time to do that. It's difficult to assess the reliability of the data. These charts are often retrospectively completed just before somebody goes into a session. So they want to please the therapist, so they fill in some data based on the recall, but this is probably not very accurate. But there's no way to know. Have they really done this every day, or did they do it 10 minutes ago? So in practice, people told us that this was often done by parents or not at all, and for children, there are associations with school, basically. It's a paper and pencil exercise, that equals homework, and not generally something they're interested in. So we thought, well, why not put this on a mobile? It's an easy thing for us to do from a technical perspective. It's a simple thing to try out, and maybe we can explore this space between sessions a bit. So young people told us that really mobiles were something that was very personally meaningful to them. So they said it was closer to the heart than any paper diary. Among the people we were working with, we did a little survey to get some direct feedback, and 19 out of 20 owned a mobile. The surprising thing, really, I suppose, these days was that one of them didn't. Part of the potential advantage of the phone is that it's a very private device. So a child could be filling in a diary on the phone and nobody knows what they're doing. Whereas if they're filling in something on a paper chart, somebody might be curious as to what's going on. It's convenient, so a child is not necessarily going to carry around pencil and paper the whole time, but is very likely to have the phone with them at all times. So if you want to capture maybe mood after anger episodes or something like that, again, this approach to charting has this availability and convenience. And again, there was this school association. When we presented this idea to children in terms of the paper chart versus the mobile chart, in which they prefer, they just said, well, that's a stupid question. You know, the mobile is clearly superior. Things on paper are like schoolwork, and on the phone, it seems less like work to them. So the implementation was pretty simple. We did this quite a number of years ago, so this was before the smartphone era, so we had to build a Java application for the phones. We sent out reminder messages to the phone via an SMS gateway, so that's turned out to be quite effective, and the content of the diary entries then came back in over a web connection. So the client then would start the application, enter their PIN, fill in their mood on a visual scale, chart their energy level, the amount of sleep they'd had, and put in a little text entry on how they were feeling. That was then sent to the server, and they could review kind of previous entries they put in. So on the server side then, we did a web interface so people could look up charts then of their data. So I work in the area of human-computer interaction, and we're generally concerned with building systems that people can actually use. And the basic technique that's used for this is called user-centered design. And as you might guess from the name, it involves getting a lot of feedback from end users, preferably observing them using systems and so on. And this is a bit of a challenge in this area. When you're talking about clinical sessions, we can't really sit in on the clinical session, kind of watching them talk about or listening to them talk about the diary. We can't follow the child around for weeks to see the occasional moments when they use the diary. So it's a slightly challenging setting for us to explore. Another issue is because of the ethical aspects of this, we really didn't want to be trying something in a clinic until we were pretty sure it would work. Okay, so we need to build up some confidence in the technology first. And a further difficulty then is therapists tend not to be very confident with technology. So really we were dealing with a very low level of experience with technology because simply in the past there haven't been a lot of tools that they would use which would be technology based. So the process then we went through to try and deal with some of these issues was to start with a simple usability trial where we're trying to make sure that the application can be used by the average person, that there's nothing confusing about it. The next step then was to try and build up some confidence that this was more engaging than paper-based diaries with a non-clinical group before moving on then to the clinical evaluation. Obviously with the usability trial and the engagement trial, we wanted to pick people who were as close as possible to our target group, as it were. So we worked with people from the same areas, the same socioeconomic backgrounds, the same ages. So with the usability evaluation then, we did this at an after-school computer club in a fairly deprived area in the centre of Dublin, with a number of 12 to 14-year-olds using their own mobile phones. And we were able to use this to identify things about the application that were hard for them to understand or which weren't very usable. Following this then, we did a school-based study where 2 schools were given a paper diary where the children were asked to fill out a diary entry every day, and 1 school, the children were given the mobile phone version of the diary. So first of all, you see that of 52 paper diaries we gave out, 18 were recovered. So this would be about the norm for paper diaries. So you're going to get very few of them back in the first place before you can even start looking at how many of them have got entries on them. Whereas with the mobile diary, 17 of these were recovered, and the ones that weren't recovered were because those children just weren't in school that day. Okay, so we're looking at a very high recovery rate there. Within the recovered diaries then, there were significantly fewer entries on the paper diaries compared to the mobile diaries, and also children pretty much admitted with the paper diaries that they'd filled in entries just before they'd arrived. Whereas with the mobile phone-based diary, we had timestamps associated with every entry, so we knew exactly when all of the entries had been made, and they'd been all made on the individual days. In some cases, actually, there were more entries on a given day than we'd asked for. So some children really started engaging with this as a tool themselves. What came away from this, obviously, we had some data which suggested adherence could be pretty good, but also the mobile diary was seen as being as easy to use as paper. They didn't see any difference. And given that paper is pretty easy to use, that was a good result. The other thing that came back out of it, even though this was a non-clinical setting, was that privacy was very important to them. So perhaps we could expect that in the clinical setting, but to get it already in this setting was maybe slightly surprising. So I'm going to talk then about the first small clinical pilot that was done in public clinics where people were used to use it across a minimum of 2 therapy sessions. And so our notion was that maybe over kind of 7 or 14 days that the diary would be used every day by the people involved. So we had 10 participants with a pretty wide cross-section of issues, and this was fairly representative of the caseload of the service that we were working with. So they weren't cherry-picking easy cases by any means. There were some very difficult ones mixed in here. Adherence then actually turned out to be even better than the school-based trial that we'd done, which, given the difficulty of some of these cases, was perhaps surprising. So participants really became engaged in monitoring their own feelings and their own mental health. But what came out of it as well, though, was that people were reflecting on the data as well as creating content that would be used in the therapy sessions. If we chart out the actual patterns of usage, so across the bottom is days, and so we've got a vertical line for every day that the diary was used. First of all, you'll see the surprising thing is just the size of the numbers along the bottom. So we expected this would be used for 7 or 14 days, and one client used it for about a year. So our adherence rate becomes a lot more impressive when you look at the scale of this. But also we see there's a number of different patterns. So client 4, for example, actually is using it on a fairly regular basis, but just not every day. So, we can't interpret low adherence values overall as necessarily indicating that it's not working. That does seem to be working pretty well for that client. The other surprising thing was the number of complete entries, as in every data field was filled in. So somebody could not fill in a text entry and just send in the numeric data. But actually, there were a lot of text entries completed, and this was also a surprise to us. So let's talk about a couple of case studies then, just to delve a little bit deeper into the nature of the use of this kind of tool. So Philip was aged 10, presented with low mood and thoughts of suicide. This is the example where the usage was actually fairly consistent, but not every day. And 78% of his entries included some text, okay, so some comment on his feelings. So the feedback then, following use of the tool from the interviews, was that the diary certainly helped recall that certain episodes initially he couldn't account for, so in terms of points where there were very low mood, but that by reviewing the text entries and so on, he was able to reconstruct what had happened. Okay, so again, it's supporting those conversations within therapy. Also, there was disclosure of details the therapist wasn't aware of in the text entries, and actually there's what's called this online disclosure effect, where people are often more honest when entering information into a computer system than they will be initially talking to a professional. So that seems to be emerging here as well. And overall, it was rated as being very helpful. Another case, which is quite interesting here, Beth was 13 and a suicide risk. In this case, the therapist thought it might be useful if they also charted the mother's feelings. And so she started using the diary, and they were able to use that information then to have a conversation about how the mother's moods were being affected by Beth's moods and behaviours, and that there was a much closer relationship there than they'd considered. And so that really opened up a very interesting conversation in therapy. Beth was on antidepressants here, which were actually affecting her ability to recall details. And so the diary, again, was really supporting them in reconstructing what was going on, because she just couldn't remember straight off things that had happened. And in this case, there was a very close correlation between the SMS reminders that were sent and when the diary was actually filled in. So it was supporting us in providing this facility to remind people to fill in their diary. I should say as well, actually, with respect to the SMS reminders, we didn't want people receiving impersonal reminders, so they would compose the reminder message themselves with the therapist in the first session where the system was introduced. And so that's a protocol we've actually repeated in other settings. Again, to illustrate, this wasn't being used in easy cases. Another child, Barry, had a long history of engagement with the service. He'd been hospitalised at one point, and he had a history of poor adherence to therapeutic tasks that had been set. So this was an interesting one because over the period of usage of this, he disengaged for a while but then re-engaged, and so again that's a pattern we might want to think about. But he started doing very detailed kind of text entries, journaling really how he was feeling, and this became a really important activity to him, and he had very high adherence to doing this. What was very interesting in this case is that he used then this journaling process to raise embarrassing issues that he didn't want to raise directly with the therapist. So the therapist, on seeing this information, would ask a question about it, but Barry didn't have to bring it up himself. So again, it's a slightly more nuanced view on what's going on in the therapy sessions that we're getting through this probe with our technology. Another thing that started to happen was that rather than going to the website to view the charts, Barry kind of took ownership of the whole process and would start kind of showing entries on the phone to the therapist. So again, we thought this was an interesting aspect of it. And the graphs, which we'd added, again, as an exploratory thing within the technology, turned out to be pretty significant in many cases. So privacy, once again, turned out to be an issue. So we'd added a PIN code when the application was started up so that nobody could accidentally go into the data. But initially we'd had a little icon and the name of the application when it was installed. And even this was too much for people. They were very, very concerned that somebody else would look at their phone. And young people do hand their phones to each other fairly regularly in terms of looking at photos and so on. And so this was an issue. So we had to change that to something completely innocuous, so MD and no icon, so that nobody would know what the application was. So it really needs to be inconspicuous. So you would have to be very careful about the use of audio, for example. But also, what we found in a number of dimensions was that giving people some sense of control was important. So for the website with the graphs, it was the child who held the password for that. And then in the therapy session, they would go in and log on to the site, and so again giving them some sense of ownership there. So graphs turned out to be a lot more important than we'd realised. In one case actually, it was a multidisciplinary team that were dealing with treatment, so psychiatrists, psychologists, social workers and so on, and they actually taped together all of the individual charts to have a kind of longitudinal kind of record of what was going on, and this was used in case discussions and with discussions with the child and with the parents themselves. So again, we'd expected this would be used over the course of 2 weeks, so we weren't expecting that people would be looking at months and months of data. So it's a nice example of them appropriating the technology and using it in their own way. As I mentioned, there were a number of interesting things that emerged with respect to broaching difficult topics and so on, and the graphs on the phone, which we'd added as an afterthought, turned out to be used on a fairly regular basis. It's worth remembering that no one approach, and particularly technology approaches, nothing's going to work for everybody. So you should always consider providing people with different options. So some people just don't want to do this on their phone. Some people might have difficulties getting kind of coverage if they're living in a very rural area. But also some people mightn't like their phone associated with their treatment. Okay, that's a barrier that they didn't want to cross, and so there should always be alternatives we're providing to people. So since then, obviously, the world has moved on in terms of technology. It was nice to be first into this area, but actually it turned out to be very difficult to do wide-scale deployment on the previous generation of mobile phones. The way applications would install was different on every single handset on the market, so really it was a nightmare in terms of trying to do any larger studies. But obviously now, with smartphones and web-based applications, really it's become a lot easier to do this kind of work, and there are lots and lots of diary applications out there now you can download yourself. We've done work ourselves on flexible diary systems, so some therapists came to us and said, well, could you do a diary with a substance abuse or alcohol abuse element to it, or an anger management diary, and so on. So really, we need the ability to flexibly produce different diary systems. In terms of future work, obviously, it'd be nice to do some larger trials now that we've re-implemented things using HTML5 and web applications. That's going to be a lot easier for us to do. Obviously, in the context of WAM, it would be nice to explore some ADHD-specific issues here. And we've got a project around bipolar disorder where we're going to be looking at sensor data, which might be informative for people. So this can be obviously movement data. The phones can record a lot of things at the moment, but also soft sensing. If somebody is checking their email every 2 minutes, it might indicate, okay, that they're an academic, or it might indicate, if they've got bipolar disorder, that maybe there's a manic episode approaching. So there could be, useful information about triggers that we could pick up from that. Okay, so I think the conclusions here I've gone through already, and so overall I would say that we found that mobile phones can help to engage young people in therapeutic activities between sessions. Thanks.
Thank you, Gavin, for giving us this overview